have a predictable, by following this protocol, you'll have a predictable workflow for left main bifurcation angioplasty, and this will lead to superior patient outcome. And you will never get surprises in the night, afternoon or evening. You have done left main, and you are getting a call in the evening or the night. Suddenly, patient collapse. Believe you me, for last 10 years, we are doing left main. We are following the imaging protocol, and it's very rare to get a poor outcome shortly, as well as a good long-term outcome. We are usually getting a good long-term outcome. So whenever we are dealing with distal left main bifurcation disease, we know PCI is a reasonable alternative to the patients, those who have a mild to moderate syntax score. And if we go by definition criteria, we know majority of the bifurcation, left main bifurcation we do, they are simple, and we get away by doing a provisional stent strategy. If we are dealing with the complex bifurcation, we know that many studies, they have shown that two-stent strategy is the answer for complex left main bifurcation. And for two-stent strategy, we have n number of technique, crush technique, culotte technique, tap technique. And we know that most of the evidence in the contemporary practice is in favor of DKC. My talk will largely be on how to use this protocol, LMBP MAAXB protocol, while doing left main bifurcation angioplasty using DK crush technique. So let me show you. It will be all my all talk will be a case-based oriented. Please stop me wherever you want to stop and ask anything. So this was 65-year-old male, diabetic for 15 years, came to me with the rest angina for 5 days, associated with the gabrat and sweating. ECG showed ST elevation in AVR, diffuse ST depression, cardiac markers were raised. Echo showed hereditary hypokinesia with ejection fraction of 45%. So this is the angiogram. So we know that yes, this is a left dominant circulation. There is some plaque in the distal left main. There is some plaque in the ostial L6, in the critical disease in the osteoprox LAD. So if you see in this angle, this is a by definition trial, by definition criteria. It's a simple bifurcation because the side branch ostium is less than 70%, the lesion length is less than 10%, and it is not even meeting the minor criteria. So even if we are not knowing the definition criteria, we all know that we'll do this case with a single stent strategy, that is a provisional strategy from left main to LAD, and bail out of the L6 if required. So I'll be showing you how we use LMBP protocol, LMBP MAAXB protocol for these kind of cases. The most important idea behind this protocol is to protocolize the workflow so that we can have a good short-term as well as long-term outcome. We know all this definition criteria for left main and non-left main bifurcation. If the side branch lesion length is more than 10, side branch diameter stenosis is more than 70, and these are the minor criteria. You need one major to two minor criteria, and the definition 2 trial has shown that these complex bifurcation do better with two-stent strategy as compared to provisional strategy. So we know the side branch diameter stenosis is less than 50%, lesion length is less than 10 mm, there's a distal plaque, and you have got osteoprox disease. So if we plan this case for left main to LAD, with the provisional approach to the side branch. So pre-PCI, whenever you do pre-PCI imaging in left main bifurcation, you have to image both main branch and the side branch. In a main branch, you have to look for the LMBP. LMBP means left main branch diameter, bifurcation, and plaque morphology. In left main, you have to look for the length and the diameter of the left main so that you can decide about the pot balloon. So you have taken run from left main to LAD. Just look at what is your length and the diameter of the left main. Okay, so that will decide your pot balloon. Then you have to look at the main branch distal reference diameter. That will decide the size of the stent. If your distal reference diameter in the LAD is 3.5, you will take a 3.5 balloon stent. If it is 3, you will take a 3 stent. And then you have to look at the bifurcation. What is the CT angle? Whether CT angle is less than 50 or CT BP length is less than 1.7. Watanabe did one study in which they showed that if a CT angle is less than 50 and CT BP length is less than 1.7, these are the cases where the side branch is at risk. That does not mean that you need to go for two stent strategy. That simply means that, okay, this branch is at side branch is at risk of compromise. Be careful. And the third thing in LMBP, that is plaque morphology, that plaque morphology and distribution of plaque in relation to side branch osteum. So I'll show you how to use this LMBP in our case. So this is the left main to LED run. This is the left main. This is the LCX opening, and this is the LED. So we measured the left main size. It was the 5.0, and the length of the left main was 10 mm. Even you can appreciate here the length of left main from carina is around 35 to 45. This is the 35 to 45. It means the length of the left main is 10. So diameter was 5. Main branch distal reference diameter where I want to place stent is 3. So that's if I want to use a single stent, it will be the size will be 3. If I want to use two stent, my distal stent will be size will be 3. So let us see the bifurcation. This is where you want to see the bifurcation. Can you see the angle of this cranial tip? Cranial tip angle is 70. It is more than 50. And let us see CTBP length. CTBP length means cranial tip to bifurcation point. Here the CTBP length is around 2 mm, in fact more than 2 mm. So in this case we knew that our side branch is not at risk of compromise. Moreover, angiographically also we know that side branch is at 90 degree, nothing will happen to your side branch. But in imaging, whenever we are doing it, we always see it. And here we came to know the plaque morphology. There the plaque is fibrotic. So here we know the left main pot balloon size I require is 510 or 5.8. The total length of stent, if I want to place my stent from here to 40, I need a stent of 40 to 45 with two stents, maybe with an overlap of 2 to 3 mm. I know that my bifurcation is favorable. I know that the plaque is fibrotic. I may need a cutting balloon to prepare my LED. And third thing is plaque distribution in relation to side branch osteum. Whenever you do imaging, always look at the L mode. So in L mode, this is L6. There is no calcified nodule opposite to the side branch. So there is no calcium opposite to the side branch. So this, whenever I'll place stent, my stent will homogeneously inflate here. It will not shift this carina. So after doing a single run, I have planned my case. I need a total stent length of 45. Distal reference diameter of my stent will be 3. My modification device will be cutting balloon 3 or 3.5. And my pot balloon size is 5.8 or 5.10. Correct? So I have planned my case. Whenever we do left main bifurcation, we always image the side branch also. So this is the LCX. So in LCX, I came to know the side branch ostial diameter is 4.54. Why we do LCX, run is I know that I don't want to do anything in this L6, but we always look at this area, whether there is any TCFA in case of abrupt closure, what is the size of stent required, anything needs to be done. So in this L6, I came to know my L6, the plaque is stable, the osteomus area is 4.54, nothing needs to be done in this L6. So we prepared this, LED not with 3.5, it's a 310 cutting balloon Wolverine. And after we prepared this, LED from mid LED to proximal LED, we placed distal stent 323 Zion Sierra from, in the mid LED. And after that, we place another stent from, left main to LED, that is 424. So the total length is 47, maybe 2 to 3 mm overlap. So total length of my stent that I have decided was 44. Distal reference diameter was 3. So before you are doing anything to left main, after you have wired, you have planned your case. This is very important. Left main intervention supplying most of the myocardium. In this case, it is a dominant left main, left side circulation. So you have to be careful. You have to plan your case with the left main so that there should be no acute, per op event that can be life threatening. So after this, you have placed a stent, you have to do pot. We knew that the size of pot, my left main is 5, so we opted for 510 NC balloon for pot. So this is the most crucial step of provisional left main bifurcation angioplasty. Whenever you, so just imagine my length of my, size of my left main is 5. I have placed a stent that is 424. So my left main stent is hanging in the, my left main to LED stent is hanging in the left main. So this is the most important point, that your wire should not come out from the left, LED, because your stent is hanging in the left main. It may go abluminally. That will lead to a lot of problem. So after you have placed left main to LED, you're the size of left main. You have to take pot balloon, and the positioning of pot balloon is the most important step. The distal marker of your pot balloon should not cross the carina. And we always recommend that it should be confirmed in two caudal views. So in this caudal view, epicranial, I am seeing that my distal marker of pod balloon is not crossing the carina, and even in this alveocaudal view, you can see my distal marker is not crossing the carina. So idea behind this is that if my this 5O balloon crosses this carina, I will, the size of my LED is 4. I will shift this carina to LED, sorry, LCX, and then this will lead to side branch compromise. So pot is the most crucial step, and the placement of the pot balloon is another important, and always confirm it in the two caudal views. So after doing pot, the most important question in left main bifurcation angioplasty is, do we need kissing balloon inflation in left main provision stent strategy? We don't have any answer till now. Till now there is no, prospective randomized control trial for this question. We do either kissing or non-kissing. Even European Bifurcation Club, till 15th consensus, they used to recommend that always go for kissing balloon inflation in left main bifurcation angioplasty for using provision stent strategy. Now they are not saying that. Even in their EBC main trial, more than they did final kissing balloon inflation in more than 90% of patient. So there is no prospective trial. There is no answer to it. Somebody, so there are few operators that goes for kissing somebody. There are few operators, they don't go for routine, kissing balloon inflation. So to answer this question, we are doing this trial, that is IKISS left main trial. And this case that I am discussing with you was a part of IKISS left main trial. In fact, this was my second case of IKISS left main. This is a prospective randomized control trial, and this design paper of this IKISS left main trial was published around 2 months back in JAC Asia. We have published it. It's freely available. You can see it, in which we have used this LMBP MAAXB protocol. So this case was randomized to KBI arm in this trial. So whenever you plan to go for kissing balloon inflation, just imagine you have done pot, your stent is here from left main to LED, you want to do a KBI, always try and cross from distal stent stud. There is no confusion in this. Because what do you want to do is, you want to cross from distal stent stud before KBI, so that your length of pneumometallic carina is not very long. So how we do it is, whenever after you have done pot, you have appropriately opposed your left main stent, we take a wire, angulated wire, we go inside the LED and gradually will pull it back so that it fall into LCX through distal stent studs. These are minute details. Once you start doing it, it actually a part of routine left main bifurcation angioplasty. So in this case, we try to enter from distal stent stud. We always, if we are going for KBI, we always try and confirm whether we have crossed it from distal stent studs or not. So this is the run after recrossing. After I have recrossed it, there are three ways of confirming whether I have gone from proximal distal stent stud. This is left main. This is LCX, this is LED. Can you see this wire? This wire has gone from proximal stent studs. Is it visible? Number one. Even in LB mode, you will see that my wire, just here, my wire is coming late after Karina. My wire is coming late after Karina. In a B mode also, just see my wire is coming late after Karina. That is another marker that I have crossed from proximal stent studs. This is not a desirable point for final kissing blown inflation. So in OCT, you can do the 3D reconstruction and you can see this is left main, this is LED that I have crossed from proximal stent stud, not a distal stent stud. So whenever you are doing a recrossing, you are checking it, you have to check from L mode, you have to check from B mode, and you can use a 3D reconstruction. And you can see even in, stent only view, my wire has entered through proximal sensor. So in this particular case, as it was a part of trial, we were successful going through distal sensor on third recross. Now you can appreciate. Can you appreciate my wire has gone through distal sensor? Initially, it was going from proximal. Now it has gone from distal sensor. Now, even here, you will appreciate my wire is coming immediately or closely after crana. Just look at here. I'll show you. Just see, my wire came immediately after Karina. And then we did the 3D reconstruction. Can you see my wire has entered through distal stent stud? So now my wire is through distal stent stud. Then we did kissing balloon inflation with 3.510 balloon in LED and 2.510 in. This was a part of our trial. So we have already protocolized what is the size of balloon required. What we do in our trial is that we take a size 0.5 smaller than the size of LCX 15 mm from the side branch ostium. So after you have done KBI, if you are planning to go for KBI, we or post PCI, we look at MAAXB. M is medial dissection at the edges. Whether your stent is well opposed or not, then you have to give 4 areas in provisional strategy. You have to give MSA of left main, MSA of LED, then you have to give ostial LED area and distal left main area. Then you have to look for separate expansion of left main and LED. Then finally, we also look at bifurcation, whether there is a clear figure of it adjacent to carina, how many stents are there after, KBI, if we have done. If there is not a KBI, we always document, okay, there's a link type or link free type of carina. I'll show you how it looks like. So in this particular case, let us see the MAAXB. At the edges, there was no dissection. Stent was well opposed. Whenever their stent is not opposed, you will see the stent studs will be red. Otherwise, all white. And moreover, there is a apposition marker here. If your apposition marker is white, it means stents, the complete stent is well opposed. Then you look at the areas. What are the areas? So let us see the left main. In left main, distal left main is 15.31. My left main MSA somewhere here is 13.74. My expansion is 84. My ostial LED is 10.73 and my LED MSA somewhere in the mid part, it is 4.76. So, moreover, my expansion in the left main is 84, my LED it is 82. My bifurcation, I could easily see clear figure of it. And if you look here, there is hardly any stent stud across side branch ostium. You can appreciate in the L mode, even in B mode, you will see. I'll show you. Look at B mode. Carina, hardly any stent stud. So after kissing balloon inflation, there is hardly any stent stud. Areas are good. Even in 3D reconstruction, you can appreciate there is no stent stud across side branch ostium. There are many case reports. They have shown that if there are stent stud across side branch ostium, they lead to fenestrated restenosis. Whether that translate into poor clinical outcome, that is not known. By our trial, we'll be knowing these things. So this is LCX post KBI run. So this is the beautiful image of our trial. Can you appreciate? This is my left main. This is LED. This is the run from LCX. Can you appreciate appropriately recrossing from distal stent stud, even scaffolded the LCX ostium? Can you see this? Even just see, my LCX ostium diameter is 4.71. After kissing, there is no dissection or thrombus. And when I tried to recross from the distal stent stud, I could scaffold the side branch ostium also. So there are some stent studs across the side branch ostium because of my distal recrossing. So we'll be, putting this image in the publication also. So this is our final angiographic result. So this, in fact, this case has completed 1 year angiogram also. L6 ostium is exactly as it is seen here. So this is another case. This was another KBI case in which we were trying to cross from distal stent stud. Can you see whether it's a distal or proximal recross? Can you appreciate? This is left main. This is LED. This is side branch ostium. This run is taken after recross of side branch. So you can easily appreciate that wire has gone from proximal stent stud. Agreed? Now here also you can appreciate this wire is coming long after carina. Just see again. This is carina. My wire is not coming. Now it is coming long after carina. So my wire is coming from distal, from the proximal. My wire has recrossed from a proximal. This is not a desirable place. So even when we looked in a 3D reconstruction, can you see wire has gone from a proximal stent stud? This is again a beautiful image and beautiful example of link type of carina. So this is left main, this is LED, this is carina. Can you see this link in at the carina? This is the link, stent link at the carina. I'll show you what is the implication of this link. So we again tried to cross from the distal stent stud. Just see. Can you see this L mode? I have tried and crossed from the distal stent and I am successful in crossing the distal stent stud. And even here, you will look at the B mode. My wire is coming immediately after current. Just see. This is, just see, wire came immediately after carina. So I have confirmed that I have crossed from the distal stent stud. Then, and we have confirmed it with the 3D reconstruction also. Can you see 3D reconstruction? So after we did the kissing balloon inflation, L mode, this L mode is showing that there are some stent stud across side branch ostium, not too many. Just see again. This is the B mode. Just look here. This is the carina. There are some stent studs. Now look at. Now just see what happened. Because there was a link, and link are the strongest part of the stent. Because there was a link, the link will never break even during, it will never break even during KBI. So there will be few stent studs that are hanging across the side branch. This link has in fact pulled the stent studs from this part of LED. Whether this will translate into poor outcome, I don't know. But we'll be seeing, we at Core Lab, we are seeing all these minute details to improve our understanding across side branch ostium. So this was the case, link type of carina, proximal recross, distal recross, and this was after KBI. So just see, critical left main, distal left main critical, presented with the NCME. Angiographically, this is one side branch, this is another side, another ramus, and this is a disease here. Can you see? So we did pre-PCR and let us see what is LMBP left main, size is 4.512. Main branch distal reference diameter where I wanted to place my stent is 3.5. Let us see the bifurcation. The bifurcation angle here is very wide and the length from CTBP length is very. But here, can you appreciate this mountain? Can you appreciate this mountain? So this is a calcified nodule, eccentric calcified nodule. So, so this is what I was talking about P. Left main branch diameter, bifurcation, and this is plaque morphology, that is calcified nodule, and this plaque calcified nodule is there opposite to side branch ostium. If I don't If I don't modify this calcified nodule, when I'll inflate my stent will get inflated toward these two branches that may compromise the side branch ostium. So here bifurcation angle is favorable, but there is a calcified nodule opposite to the side branch ostium. So in this case, we modified this calcified nodule. Can you appreciate this mountain? Deep cut in the mountain, deep cut in the calcium, and this mountain get suppressed. Your minimal lumen area here, it was 1.74 here in the distal left main. Now your area is shifted from 1.74 to 5.32. Can you appreciate? It's 5.32. So in this case, we place a stent from left main to LAD. Again, this is a crucial step. You have to do a pot. You should confirm that that distal marker should not cross the carina. So this is carina. My distal marker is not crossing the carina. And after we did the pot, we did the MAAXB also, and when we analyzed the MAAXB, we found that your areas are good. My left main MSA is 10, my distal left main is 9.8, LAD MSA is 6.85, and expansion is 85. Ostial LAD was 6.79. We inflated it after that, and we got an area of around 7.2. So this is a side branch ostium. This case was randomized to non-KBA arm. So this is a stent stud that is hanging across side branch ostium. And we have to see what happens to these hanging stent studs. So this was the final angiographic result. So there was a calcified nodule opposite to both the branches. After we did left main bifurcation angioplasty with a single stent, and after doing appropriate modification of the nodule and doing a pod, just see all branches are flowing adequately. So this is the way we plan our case. We protocolize our, left main intervention using imaging so that there is no confusion, there is no surprise in and and we anticipate that this will result into better short-term as well as long-term outcome. So this is an interesting case. Left main to LAD. Can you see this is a carinal tip? Narrow carina. Those who do a lot of fibers, they will correlate it with the spiky carina. So when we measure the CT angle, it was less than 50. This is the carinal tip and this is the bifurcation point. When we measure the CT BP length, it was 0.9. So Watanabe did one study that showed that if your CT angle is less than 50 and CT BP length is less than 1.7, this branch is at risk of side branch compromise. This does not mean that you need a two-stent strategy. This means that be careful. You may have a compromise. You may need to address it. So in this case, when we play, and third very important thing in this run is, can you appreciate this nodule opposite to side branch ostium? So all these three things are making this side branch at risk of compromise. So when we placed our stent from left main to LAD, can you see this? Can you see this? My carina got shifted, and you can appreciate here. So this is the opening of, this was the opening of LCX before putting in stent, and just see the amount of opening. So my carina got shifted. So I knew it before, and our stent, when our stent got inflated, it compromised the side branch of ostium. After doing pot, we rewired the wire. We did a kissing balloon inflation, and this carinal shift, we againly centralized this carina, and this was a side branch opening. So carinal tip angle, CTBP length, and plaque morphology opposite to the side branch ostium, they are predictor of side branch compromise. They don't, that doesn't mean that patient required two-stent strategy. So this is a various scenario after pod. Many times when you do appropriate pod, you may not have a stent stud across side branch, or you may have a stent stud across side branch. This is an example of link-free type of carina. This is the carina, there is no link. This is an example of link type of carina, but proximal recross. This is again example of link type of carina. There is a link, there is a link, This is an example of proximal recross. This is an example of distal recross. The ideal scenario, you cannot control link type or link free type of cranial. Whenever you will place a stent from left main to LAD, there are around 50% of chances you will have a link type of cranial or link free type of cranial. The ideal side branch ostium will be link free type of cranial with distal recross. Second type will be link type of cranial, but again a distal recross. Whenever you will cross from proximal stent stud, you will push these stent stud across side, carina. You'll have a longer new metallic carina, and there's computational flow studies have shown that these side branch they don't do well. The idea behind distal recross is to have a shorter length of new metallic carina. Moreover, to scaffold the when I am crossing from the distal stent stud, I'll take the stent studs towards side branch ostium when I'm doing KBI. These are the various type of pot that you can anticipate after. So these are various type of side branch ostium that you anticipate after doing a pot. So not only OCT, whenever you have recrossed your side branch ostium, you can confirm your wire position even on IVUS. Now look at here. I'll start from here. So this is LAD. This is LAD. This is a carina. My wire is coming long after carina. Just imagine you are coming from LAD, your carina came, but wire never came. Wire is not coming. It's coming long after carina. So it means my wire has crossed from proximal stent studs. Now, this is you can use in our trial and or in our routine practice, we use a lot of L mode of IVUS, and we have observed that this is not commonly used, but it is actually a very useful mode of IVUS. Can you see this is a left main, this is LED. Can you see my wire has gone from proximal stent stud? Same case, proximal stent stud. So not only OCT, with even with the IVUS, you can confirm the position of your wire in the side branch ostium, and you can recross it before doing kissing balloon inflation. So whenever you are going for left main bifurcation angioplasty using provisional stent strategy, we recommend use of left LMBP MAAXB protocol, and we are a very this protocol will have a you standardize your left main intervention. It will be your left main intervention will be planned. There will be no surprises after you leave the hospital, and most importantly, we have observed very good short-term as well as long-term outcome, because these are the left main that used to go for CABG. Now we are doing it, and they deserve a better protocolized way of doing it. So always look at LMBP, left main length and diameter, main branch distal reference diameter, look at the bifurcation, CT angle and CTBP length, look at the plaque morphology and distribution with respect to side branch ostium. During PCI, confirm your guide wire position in three modes: L mode and B mode when you're doing using IVUS. If you're using OCT, do a 3D reconstruction also. Post PCI, look at medial dissection, max B, look at medial dissection, apposition, areas. You have to give 4 areas. I always say, whenever you're doing left main intervention, always this report areas are report card to the patient. Okay, if I have done appropriately, if I have appropriately done left main intervention and I have achieved good areas, like I have cases I have shown you 10, 12, 15, I know that most likely these patients will have a good long-term as well as short-term outcome. Always look at the expansion separately in the left main LED, and always look at the bifurcation for number of stent studs, link type or link free type of carina, and a clear figure of it. All these things improve our understanding of side branch ostium. And when you are doing left main bifurcation angioplasty with provision stent strategy, what if your side branch is angiographically optimized? Compromised. Always look for if there is ECG changes. No, you have done a left main to LED stenting, you have done a pot, Your LCX is looking 50%, 60%, 70%, or 80%. There is no ECG change. There is no chest pain. There is TIMI3 follow. Look at the FFR, like less than 0.8. Nothing needs to be done. But if any of this is positive, you have to go for intervention of the side branch, maybe for a routine KBI, maybe inflation of the side branch ostium with the DEB, or maybe placing a stent in the side branch. And there are the three techniques for side branch bailout. One is TAP, second is QLOT, and third is reverse crush technique. So this LMBP MAAXB protocol is not only for provisional stent strategy, even for two stent strategy, you have to look at the left main, you have to look at the main branch as side branch distal reference diameter so that you can plan the size of both the branches. You have to, whenever you are going for two stent strategy, this bifurcation, you don't have to look at CT angle or CTPP length, but yes, you have to look at the plaque morphology, its relation, and plaque morphology of both main branch and side branch. And whenever you are going for two stent strategy like DK crush, you have to confirm the positioning of side branch recrossing, like for first recross proximal and second recross distal. And MAAXB is same as that of provisional stent strategy, but the only difference is you have to give 6 areas to the patient. You have to give MSA of left main LAD and L6. Then you have to give distal left main area, ostial LAD area, and ostial L6 area. And these areas, now we have a target of 6, 8, and 12, which we started from 5, 6, 7, 8 from Kang's criteria, but actually, I always feel that that was misinterpreted as a target. That was not the target. That was the area below which there was a very high MACE rate. And whenever you are using two stent strategy, you have to look for clear figure of eight or dumbbell sign that we have published. You have to look at the L mode for the length of new metallic carina, and you should look for 3D reconstruction for hanging stent studs. So this is my last slide, imaging essentials or imaging pearl of left main bifurcation angioplasty. Imaging is must for left main bifurcation angioplasty. There is no doubt about it. There are n number of trials in favor of this. There are n number of meta-analysis that has shown that left main bifurcation angioplasty, till now we have got a class 1 indication recommendation for using imaging for left main intervention. We recommend always you image both main branch and side branch. Pre-PCI, use LMBP. POT is the most important step. Give sufficient try. Don't be in hurry of while doing POT. Take a POT balloon, place it in the left main, and confirm the position of your POT balloon. Give sufficient time. It should not cross the carina. Use image to guide the wire recross during left main bifurcation angioplasty, as I have shown. Post PCI, look for MAAXB BP. Always try and achieve imaging targets of left main bifurcation angioplasty, but not at the cost of safety of the patient. And POT should be the last step before coming out. So October trial, they showed that 9 to 12% of patients, they have USD. USD mean unintended stent deformation. So in core lab, they identified that 9 to 12% of patients have stent deformation. That was likely because of the guide. So for last 2 years, whenever we have done everything with our left main, two stent or one stent, after we are done imaging, after we have done final angiogram, we always do POT as our last step. After I have done POT, I don't touch my left main with the guide. I just come out. So POT should be the last step before coming out. This was my last slide. And thank you very much. Any questions, any comments?
So, Dr. Ankush, the latest studies, they are suggesting that probably we won't need imaging if you are experienced enough for left main interventions.
This is what I was waiting for, and I actually wanted that somebody should ask this question. So there are two trials that came into in NEGM. One was the optimal trial, and the second was IVS chip trial. Both studies showed that there was no incremental benefit of IVS over angiogram, but one has to read this trial, one has to see the detail of these trials. You know, the average number of cases these operators used to do yearly was from 1,000 to 3,000 cases yearly. Number one. Number two, in fact, I take this trial positive for imaging. I'll tell you how. All these operators, they used to use IVUS for majority of their left main intervention. So if I do all my left main intervention with imaging, if you tell me to do a case without imaging, yes, I will do it without imaging, but I will use, you cannot, you can ask me to do the case without imaging, but you cannot ask me don't use my imaging brain. So that is what was used in that trial. All the operators, those the involved in that trial, they were very well experienced even in the imaging. So actually this was a win-win condition for the imaging. So imaging has made those operator where when they were doing left main intervention, even in the angiogram, they were using their all experience of the imaging. So we, in fact, we have written a letter to editor also that this trial should be generalizability of this trial should be used with the caution. These trials should not be given a message that left main intervention should not be done without imaging. In fact, all the operators that were doing angiography guided left main intervention, they were very well versed with the imaging guided, intervention. That was the key result of the trial.
Thank you.
Dr. Ankush, Saujate here. So,
Sir,
what about kissing? So, you are talking about maintaining a side branch which does not have any links. So, I think intuitively we can kiss every case, provisional or not, so that we don't have any links across the side branch.
so the simple idea behind is in two-stent strategy, final kissing balloon inflation is mandatory. There is no confusion in that. That is written on the wall. So that is how we have evolved from.
Yes, in provisional, yes.
Yeah. So in two-stent strategy, KBI is the answer. KBI, you have to do it. But in provisional strategy, there is. So why we are doing this trial? Just for information, the sample size of this trial is 1,100, and we have done around 600 cases. And what we want to answer with this trial is for all the operators, those who are using imaging or not, whether routine KBI should be done or should not be done. If I see myself 2 or 3 years down the line writing the manuscript, I think I may be writing that use imaging. Just see if there are no amount, there are not, if you are using imaging, if there are not a large amount of stent studs, kissing is not required, because we have seen 30% of time after pot there are no stent studs across side branch ostium. But I think this trial will answer this question. Till now we don't have answer, but in all the trials, left main, non-left main trial, there was no difference in the clinical outcome between KBI and non-KBI.
Plaque protrusion in the left main bifurcation compared to plaque protrusion in non-left main bifurcations or non-left main lesions. Is there a difference? Whether will you be extra careful if it's in the, say, opposite to the carina in the ostial LAD, places like that?
Yeah. So plaque protrusion, we deal it in the same way in all the scenarios. So plaque protrusion is seen mostly in the lipid-rich plaque. Most of the left main we deal, they are usually fibrotic, and they are calcified. Plaque protrusion is not a or not a big deal. But if the plaque protrusion is severe enough, so the mild moderate severity index is there. If plaque protrusion is severe, it is recommended to do a balloon dilatation. If balloon dilatation doesn't, resolve this plaque protrusion, they say that go for another stent placement, because massive plaque protrusion means that that compromise of the lumen by more than 50%. This has been linked with the acute stent thrombosis. So we don't, separately deal left main and non-left main plaque protrusion, but usually left main plaque protrusion are not very common, because most of the left main, they are old age, they are, most of the left main, they are either calcified or fibrotic. But yes, if there is a plaque, say massive plaque protrusion, you need to deal it with either with a balloon dilatation or another stent placement.
Hi, Ankush. This is Dr. Sumit.
Sir,
What are
good
your
evening.
thoughts about pot? Some have advocated recently that you can do two-step pots. The first with a balloon, which is similar to that of the main vessel LED, and then subsequently you upgrade the size of balloon similar to that of left main. The first balloon being close to the ostium of LED across the carina, and second balloon just proximal to the proximal edge of the carina.
Sir,
So
again,
is
this
it
is a, yeah.
different? Yeah.
So this is again a great question. So idea is, when we are using imaging, so just imagine my LED is 4 in osteoprox, but where I have landed my stent, that was 3.5. So I have used a 3.5 33 stent from left main to LED. Just imagine. So this is the case when I am doing post dilatation, I have seen imaging, I will land in a normal area. And for the dilatation of my proximal LED, I will use a 4 balloon. Because if I have sized my LED appropriately, if my LED size is 4, post dilatation with the 4 is required, that will not lead to shift of carina, because my size of LED is 4.
Yes.
And now my left main is 5.5. So I need to oppose it. But this 5.5 balloon should not cross the carina. So if this will cross the carina where LED is 4, I am taking my balloon there, it will lead to carinal shift and side branch compromise. So that is why we always say you have placed a 3.5 stent in left main, that is 5.5. There are 2, 3 things. Be very careful that your wire should not come out. Number one. Number two, always immediately take your pot balloon inside the left main. Position your, don't be in hurry while doing pot. Just see, confirm it in 2 orthogonal views that you have not crossed the, many times in alveocaudal, your L6 is going down. You will not be able to appreciate. In that case, RA caudal is better view. So we always confirm in 2 caudal views whether my distal marker of my pot balloon, it has crossed or not. And there are 3 benefits of doing appropriate pots. First is, you will oppose the stent to the left main, number one. Number two, you will take your stent struts towards side branch ostium. That will depend upon the angle of bifurcation also. But if your angle of bifurcation is less than 90, while you are doing pot, you will take your stent strut across side branch ostium. And third benefit is, you will open your side branch ostium for future course. And third thing that we observe in narrow angle is, you will scaffold the side branch ostium also. So we always will, if there is some disease, your sensor is towards the, that I showed you in one of my image. Clearly, in fact, we'll publish that image in our article, that my sensors have scaffolded the side branch ostium also. So that is the benefit of doing appropriate pot. Another thing that is being very commonly debated is how to do a pot. Just imagine your left main length is 15. Okay, you have placed your stent from left main to LED. Now pot should be done from proximal to distal or distal to proximal. There's a big debate about it. In fact, there was one image article in Euro Intervention by Dr. Himanshu Gupta. They have showed that if you go from distal to proximal, that we routinely do, your stent gets elongated. So after that article, we did n number of bench studies. We found that if your stent is coming till ostium, this is what practically we use. If your stent is coming till ostium, we don't want that this stent now will come out of ostium. We first oppose our ostium proximal. If I am doing a left main intervention, in my left main length is 15 and I have covered only 10 mm of left main or 12 mm left main, I'm not worried about elongation of my stent towards the ostium. I'm not worried. So in that case, we always come from distal to proximal. So always come from distal to proximal, except when you are hanging your stent stud. In that case, you may elongate the stent stud, because the vice versa is also correct, that they have not mentioned. If you are going from proximal to distal, you will crowding the stent stud toward the side branch
Yes.
ostium also.
Yes.
Ostium also. This is our plan. I don't know when will be able to do it. This is our plan of doing a randomization proximal to. If any of you are interested, just tell me. I'll write a protocol. In fact, my protocol is ready. We wanted to randomize between proximal to distal and distal to proximal, pot strategy. So in practice, what we do, if I am not concerned about the left main ostium, I always come from distal to proximal. If I'm hanging my stent just at the ostium, then I first oppose the ostium so that I'm not hanging too much, because if it elongate from distal to proximal, my hanging will get increased.
I think here also report is going to correct many of these deformities. But what you were talking initially, that you must do report before you finish.
So in my lab, and I have seen many operators, last thing that we do, well, I have done my imaging, I have done my shot, I'm very happy with the case. I just take my 5O balloon. Now I'm not worried about carina end. I just take my 5O balloon. In an epicranial view, I just confirm my position that I'm able to oppose, or I am able to inflate my proximal part of stent. Gentle inflation 6-8. After that, I take out balloon and wire. I don't do anything. I don't touch my left main, because that 10 to 12% of USDs, they were great, and that will lead to a poor long-term out. So last thing for last 2 years, you will see, if you see come across my case, last thing is balloon coming out and wire coming out. No injections after that.
Perfect. Thank you.
Any other question, sir?
I think you everyone have understood. I think it took me your 2 lectures to understand exactly what you are saying. This was my second time that I've attended it.
Sir.
But I get your points.
So this is what we are doing for last 4 years, sir, working on it, doing every case, learning it, doing it again and again, learning it. But I think I always, at least I can say this in this forum at least, left main intervention deserves some respect. You cannot do it, यार कुछ नहीं मेरे को करना, ला करके आ जाओ. Because these are the cases. If you want to have a good short-term as well as long-term outcome, I strongly feel that you have to do in a planned way. And once you have planned it, your intervention will be so smooth, and it will be added, like in all my left main reports, whatever I have spoken, LMBP and everything, I always write it. I have printed it, and it's very easy for everybody to write it down. Okay, give it this to the patient, and it gives the impact of the lab also, that how you have done your case. Left main bifurcation, 2 stent, 1 stent, patient coming to you after consulting with for a CABG, and they don't want to go for CABG, and you want to give a result as good as that of CABG. I think left main deserve this kind of attention, detail, and respect.
Do you have any experience with those dedicated bifurcation stents which have an opening towards the L6 ostium?
So these dedicated bifurcation stent, they are actually nothing. They are kind of doing left main bifurcation using culot technique. What they have done is they put a stent in the side branch first, and there are 3-4 anchors that come in the main branch. So it's actually nothing. It's doing left main or bifurcation angioplasty with two stent strategy using a culot technique. The only issue with the culot technique that comes to my mind, there are two issues. One is you have a double layer of stent in the main branch or in the left main. Second, you take out your main branch wire in during culot technique. In DK crush technique, in provision strategy, you never take out your main branch wire. That is the beauty of doing these two techniques. So dedicated bifurcation stent, they are good. It's like doing a culot technique with less of the metal in the main branch. Yes, I have used few. I think Asif sir was saying something.
मैं कह अंकुश, कैन यू हियर मी? आवाज आ रही मेरी?
Yes, sir. Yes, sir.
मैं कह रहा अगर यही पूरा जो स्कोर है अगर आइवस से होता तो क्या डिफरेंट होता? बिकॉज वी
कुछ
आर
नहीं
डीलिंग विद
होता,
लेफ्ट मेन एंड इमेजिंग,
कुछ
मतलब
नहीं.
आइवस वुड हैव बीन बेटर इन दैट स्कोर, या ओसीटी हैज क्रिएटेड सम स्पेशल डिफरेंस
So, so, so,
regarding this
so,
LMBP and MAAXB score?
so I use this LMBP MAAXB both during IVAS and OCT.
Okay.
You can use IVAS as well as OCT for the only difference
And
between
what do you, you think they are same?
absolutely same, absolutely same. My my only my So my only recommendation is that imaging should be used. And if you are doing left main with imaging, do it in a protocolized way with the LMBP MAAXB protocol. You can add it into your reports. What was the left main side? What was the morphology? What was the is there any nodule opposite side branch osteum? So you can do everything with the IVAS except for 3D reconstruction that has not got a great value, but that for learning purpose, it is of great value. If you want to learn something, I always feel OCT slightly better than IVAS, but for a patient point of view, for doing an intervention, I think IVAS is as good as that of OCT. There is no confusion. Personally, if your left main is small, if I know that I am coming to the ostium of left main, I'll use IVAS. If I am doing only distal left main, I have got a sufficient room in the left main, I use OCT because the OCT, it gives me more detail as compared to IVAS.
And you have submitted this work at international level? Matlab, yeah, it is ongoing. You have shown this work to international bodies. Yeah, you are still continuing with this. It has been published already.
So this was this is part of our this is part of our IKIS left main trial protocol, but we have used it, we have discussed it, and this is actually nothing a sum up of doing left main intervention in a planned way. That's it. And
yeah.
So you have done an imaging pre-PCI, you know what is your left main size, main branch, you have planned your case.
Yeah.
So if you have planned that you want to put a stent 428 in left main to LD, that is there, your technician has taken that stent, you are doing pre-dilation, anything wrong will happen, la bhi stent la fatawa dala pot ke bahar aa gaya. This will improve the outcome because you're dealing with left main.
Yeah, more disciplined and more planned way.
Yes,
There's
sir.
more protocols. Yeah,
Yeah.
good. Nice, very nice presentation, and I've learned so many things regarding this score.
Yeah.
Any question from Smith or Sajate?
No, sir, I think that's wonderfully summed up from my side.
Yeah. Okay, if there's no question, then
Yes,
I
Asif
think
sir,
we can wind up.
yes, if you can give the closing remarks, Asif sir, then we can close. Yes.
So I think we have a very lucid presentation by Ankush, and we have learned that is a definitely left main and needs a better dignified way, better disciplined way. That is, we should be prepared with all these points. And he's tell very in very much detail that is what happens when side branch is compromised also. And the left main stenting still needs so many improvisations, and Ankush has dealt with this subject to the core in a very better way. And definitely this score helps. And ideally, no left main bifurcation stenting should be done without imaging. And I can see many publications which he has done. I will go through it in this coming week, and definitely something is added so that we can do it in a better way. A very nice presentation, Ankush. Thank you. If there is no other question, I think we can wind up this session.
Thank you very much, sir.
Okay, fine. Okay, thank you. We'll meet again, Ankush, soon. Okay, fine.
Pakka, sir. Thank you, sir.
Okay,
Bye, sir.
bye.
Good night. Bye.
Good night, Sujata, sir. Thank you, sir.
We can stop recording.